Mm. All right. Well, welcome everybody. Happy Monday. It is my pleasure to introduce one of our Barrow rotating residents. So Nick Rabah has been with us for the past 2.5 months. He has a little bit of December left with us. And Nick did his undergraduate at the University of Michigan and then did his medical school at Case Western Reserve University. And it has been a pleasure to have him on service with us. And today he's going to be talking about sellar lesions in the pediatric population. So take it away.
All right. Thank you, Dr. Bristol. It's been a very fun 2.5 months. I've learned a tremendous amount. It's been great working with all the staff and everybody here, and excited to give a grand rounds talk on what is a fairly common entity in adults, but turns out to be a fairly uncommon disease process that we see in children, but I think still nonetheless important to know about, be able to diagnose appropriately and treat appropriately. And so with that, I'll get started. So uh, there are about 4,000 new central nervous system tumors that get diagnosed in the pediatric population each year. Sellar parasellar lesions account for about 400 of those. So it's fairly, as we mentioned before, a fairly small amount, relatively uncommon. And if you think about all the number of pediatric centers in the country, that's not too many per center per year, especially with the vast majority of those being craniopharyngiomas, which is something that we won't touch on today. But but that makes pituitary adenomas specifically, or intrinsic cellular lesions, far more uncommon, and they have their own unique challenges, both in regards to mass effect and endocrinopathies. And I thought, to sort of drive home that initial point of these being difficult, I put a few quotes just from some prominent people in the field of neurosurgery and neurosciences. And so one is the benign histology of these tumors is often marked in contrast to their malignant clinical course in children. And so it's an important point. And, while it's important to give, hope and realistic expectations to patients and families when they are diagnosed with these, especially given their, WHO grade 1 tumors often, their clinical courses can be very difficult, and they can, be plagued by endocrinopathies, neuroophtho deficits as a result of both the disease entity itself and the treatments that we use to try to achieve cures, and these can be lifelong diseases. And then another quote here: the location of cell lesions, which have an intimate association with the visual pathways, hypothalamus, limbic system, predisposes patients with these tumors to severe visual, endocrine, cognitive deficits, both at presentation and result of treatment, which is exactly what we were talking about. And although most children can compensate for these and the endocrinologic deficits, the cognitive and psychosocial sequelae may be functionally devastating, interfering with education, limiting independence, and adversely affecting the quality of life of these children. And so, some of the more, non one of the things that we think about less frequently are those psychosocial and cognitive deficits that can happen as a result of treating these kids, and the hormonal imbalance that can result, and that can have a really difficult course for them. So it's important to diagnose and treat these early, as well as understand those downstream consequences to be able to mitigate those as much as possible and provide them with the best chance for a good quality of life. So with that, we'll talk about some of the objectives for today. We want to first discuss the anatomical origins, because this wouldn't be a neurosurgeon giving a lecture without some rote images and some anatomical origins of things, as well as talk about some clinical presentations of these common cellular lesions. We also want to evaluate the medical, surgical, radiotherapeutic treatment modalities involved in managing cellular lesions, and then finally identify the factors that influence prognosis, discuss the potential long-term complications, including, like we talked about, those endocrine and neurocognitive effects. So we'll start with some simple embryology. Um, the pituitary gland and the cell itself come from a combination of two different tissue origins. So oral ectoderm, eventually forming the adenohypophysis, and then the diencephalon lumen, or the neural ectoderm, forming the neurohypophysis, or the posterior pituitary. And as we can see, the invagination that happens over the course of fairly early in fetal development, in the first several weeks, We can see Rathke's pouch forming, the infundibular process forming as we start to get the anterior and posterior pituitary with the interglandular cleft that ultimately, holds the cells that we see form Rathke's cleft cysts and craniopharyngiomas. But then in red, we see the anterior pituitary, and then in yellow or orange, we see the posterior pituitary form coming from distinct tissues, but ultimately invaginating within each other and forming one gland that we see now. So, moving on a little bit to some anatomy, I think many people here probably know this anatomy fairly well, but I think to just get everybody on the same page as to what we're dealing with, what is surrounding it, and ultimately serve as a framework for the types of issues that we can see with mass effector lesions in this area. We'll look at some rodent images, and first off, you can see this is on the right, an endoscopic view, actually, where you're looking through the nose. The sphenoid sinus is kind of removed, the bony covering is removed, and you can see right in the center of your screen, that's our pituitary gland. There should be a wall of the cavernous sinus, which is actually removed in this image on the right. You can actually see the blue there in the diagram on the left, indicating the cavernous sinus and the carotid as it runs through there, and the ophthalmic arteries coming off. These are the optic nerves with the optic chiasm. And then above the optic chiasm, you can see here the anterior cerebral arteries, the hypothalamus, and then posteriorly the third ventricle. And it just kind of shows the intricate relation of all of these structures within the cellular and supracellular region, and how very small lesions can have very big impacts as far as visual deficits, endocrinopathies, even hydrocephalus if the third ventricle is obstructed in larger macroadenomas. And then the same diagram here on the left, but then in a post-contrast MRI to show you, what we can see with detailed neuroimaging. Here we have a coronal section of the MR post-contrast showing the optic chiasm, the carotid arteries. Here you can see the very well-defined cavernous sinus with the cranial nerves within there, and then the pituitary gland and the stalk coming down. Here, this is just a normal gland, which can show some hyperintensity on post-contrast imaging. And then looking from the top down, this is a view that we don't really see too much anymore, as traditional open cranial approaches have gone away to treat these lesions. But we're looking from the top of the head down, and you can see optic chiasm again, the optic nerves. You can see the posterior communicating arteries, the third nerve here. The actually hypothalamus has been split to give you a view into the third ventricle down to the cerebral aqueduct, and then the infundibular and pituitary stalk is retracted anteriorly to give us that better view. But again, showing that even millimeters of growth or millimeter type lesions can have significant effects. So I'll move away from all the anatomy, any physiology, and we'll kind of go into disease specific things now, talking about specifically pediatric pituitary adenomas. And they account for really only 2 to 6% of intracranial neoplasms in kids, and they can be hormonally active or inactive, as we know, most common in children being prolactin secreting adenomas, ACTH secreting adenomas, and growth hormone secreting adenomas. And these are in contrast to adults, where we see the majority of lesions being non-functioning pituitary adenomas or prolactinomas, whereas in kids we see much more commonly the hormonally active adenomas. And the major kind of hallmark of these lesions, and I think this goes with all of medicine, but I think with specifically pituitary lesions, is diagnosis guides treatment ultimately. And just seeing a lesion on the MRI or on a CT scan is not enough to guide your treatment. There's a smattering of biochemical tests, understanding the specific presentations that these patients come with, which ultimately guides the treatment paradigm that we will ultimately use. And so obviously I'm young in my training, and so I jumped right into biochemical tests and imaging before I get into the before I get into the history and presentation of a lot of patients. But ultimately, when we do see and we do get called about patients who have lesions in the sella, the first thing we do is we get a whole battery of pituitary function testing, and this just reflects the different hormones that the anterior pituitary produces. ACTH, cortisol. We'll get it both at the time of the call and then in the morning as cortisol levels change throughout the day. We'll get FSH, LH, growth hormone or insulin like growth factor 1. We'll get prolactin, and we'll talk a lot more about prolactin as well. Thyroid stimulating hormone, free T4. And then we get a BMP and urine labs because the posterior pituitary can be involved indirectly as well as adenomas grow. And then we move on to some diagnostic testing, neuroimaging, and ultimately that gives us an idea of the anatomic relation of the mass, the laterality of it, which can help guide treatment decisions, as well as it helps kind of some classification stuff. So pituitary microadenomas being less than 1 centimeter in size and macroadenomas being greater than 1 centimeter in size. Ultimately, these lesions can present a little heterogeneously on MRI. Microadenomas typically tend to be isointense to the normal pituitary on T1 imaging. Really specific pituitary sequences with post-GAD contrast and enhanced imaging will give us the best look at these, as the microadenoma tend to have a delay in their contrast enhancement compared to the normal pituitary. And so we can take advantage of that to kind of help differentiate between the two, as it can be difficult to tell, as well as the infundibulum will be seen deviating away from the side of the adenoma as the mass effect pushes the pituitary gland in one direction. And then on T2, it can be variable, but they can often be a little hyperintense. Here we have a coronal image T2 where we see it being isointense here on the right side. Macroadenomas, main difference here is that as a result of their growing size and sometimes their propensity to hemorrhage, we can see some heterogeneous signal within them, as well as some what we call fluid levels, as hemorrhages can layer and show distinct layering on contrast or on T2 imaging as well as post contrast imaging. And then we get into presentation, and depending on the hormone secretion or the hormone imbalance that's presenting, they can have differing clinical presentations. Prolactinomas often present as amenorrhea in girls at the age of puberty. Corticotropinomas or Cushing's disease, or will present with Cushing's syndrome, and that will be weight gain, growth failure, which is in contrast to that in adults, as well as premature puberty in prepubertal children. And then a somatotropinoma or growth hormone producing lesions will produce gigantism, as well as things like diabetes, visual disturbances, headaches, heart issues, cardiovascular abnormalities. And then finally, again, in contrast to adults, the unfunctioning adenomas, which are more rare, are typically asymptomatic, but may present with things like headaches and visual disturbances. Diving into specifically prolactinomas, we'll start and we'll go through kind of each one in a little bit more depth before going into kind of cases. So the first thing is, again, confirming that diagnosis of prolactinoma, and that starts with the history and physical. Females, from an endocrine standpoint, will have galactorrhea. They have delayed puberty as well as amenorrhea, and less frequently will have visual disturbances, whereas males, the primary symptoms that we will see much more frequently are going to be headache and visual disturbances, and that's just as a result of kind of some of the delay in presentation, some of the tendency for those to be a little bit larger. But we also do see fairly frequently gynecomastia and galactorrhea. And in children, this can be a little bit more difficult because as they reach that pubertal age, they can naturally have a few of these things, which can delay diagnosis often in a lot of these kids. Sometimes it can be years of these symptoms before we truly see them coming about. And this is just to redemonstrate, to kind of drive home, these are the major symptoms that we'll see in each gender. Biochemical analysis. So often, like we mentioned, we'll draw all of those labs, a smattering of hormonal labs, but we have to be able to interpret them. And kids, as they develop and as they grow and as they change, their prolactin levels differ and they can go, up or down as we reach the pubertal age. And we just have to know that with these kids, you don't have to memorize the values, but there are age-specific norms. And often what we look for to diagnose a prolactinoma versus things with just what we call stock effect, which we'll get into a little bit, we typically look for something that's 6 times the upper limit of normal. And if above 6 times upper limit of normal, then we can say that, it's a prolactin secreting adenoma and not just the result of compression of the pituitary stalk. And so typically, this is based off of adults, but we use it in children as well, is we look for anything greater than 2,000 milliunits per liter or 94 micrograms per liter. And that's typically much greater than 6 times the upper limit of normal. And this accounts for things like stress, physiologic changes like we talked about, should not produce levels this high. So imaging shows a hyperintense lesion in the sella. We have an elevated prolactin level. We have a child with either amenorrhea, galactorrhea, or ophthalmologic disturbances. And we say, okay, it's something that needs to be treated. How do we do it? Dopamine agonists, they are usually our initial treatment of choice. And I have emphasis on usually because we'll talk a little bit more about some of the new treatment paradigms or discussions that are happening. And those are the treatment of choice because they work fairly well. They lower prolactin concentrations in up to 70% of cases, reduction in tumor size in up to 90%. And with that comes improvement in visual field deficits. They resolve the pubertal delay, and they eliminate the headaches that a lot of these patients have. Now, typically, bromocriptine was the initial drug of choice, and it's been used since the 70s because it was more efficacious as compared to, like we talked about, those big open surgical approaches, which were high morbidity, working in a very delicate area, having to work around a lot of those sensitive structures like the hypothalamus and the optic nerves to try to get to the pituitary gland. If we can use a drug option that can help reduce tumor size, improve the hormonal imbalance, then why not? And it works by binding to the D2 receptors in the lactotroph cells on the pituitary gland, which inhibits that production and secretion of prolactin and effectively shrinks the tumor. And we'll keep moving through that. However, 1994, we switched over to cabergoline, which is now the drug of choice that we use in the standard of care today. I'm sure everybody here has seen patients of theirs that have been placed on this for presumed prolactinomas. And that was a result of this trial, which was published in the New England Journal. And ultimately, the switch was due to cabergoline showing greater reductions in prolactin, greater rates of restoration of gonadal function, as well as a decreased side effect profile as compared to bromocriptine. So it was a nicer drug, less frequent dosing with more efficacious treatment results. And so then here's a kind of a treatment paradigm that we use nowadays for prolactinomas. And like I mentioned, usually the treatment of choice is cabergoline or medical therapies. However, more and more, especially as surgical options have become more safe, operative corridors have given us, or through the nose, transfemoral approaches have given us the ability to reach these adenomas while avoiding a lot of the sensitive structures that we typically had to use. There's actually a developing role for initial surgical resection for prolactinomas, sometimes even prior to starting medical therapies. And highlighted here is kind of the treatment paradigm that I'm talking about. And that's for macroadenoma is what we call NOSP grade 1. And I'll get into the NOSP classification and grading here in a little bit. And there's a series of patients who might meet the appropriate criteria for initial upfront surgical resection to, one, try to achieve surgical cure without the need for long-term medical therapy, and can achieve a good result. And so those are who are young adult age, who one present with rapid visual loss, and you can't wait for medical therapies, but we won't focus on that now because that's a more clear indication. But ultimately, it ends up being these kind of young females with well-encapsulated NOS grade 0 or 1 grade tumors who have the opportunity to avoid being on long-term medical therapies without the risk of hypopituitarism that came with the traditional open surgical approaches. But to define the NOS grade so we know what types of tumors we're thinking about, we'll get into a little bit. It's a classification system that's based off of MR imaging, which shows and uses the kind of degree of encroachment that the adenoma has on the ICA, but really it's a proxy of the invasion of the adenoma into the surrounding tissues, and then the chances for gross total resection and then endocrinological remission. And as we can see, as the NOS spread gets higher, which means the encasement of the carotid happens more, there's a higher chance of histological invasion into those tissues and then a lower chance of remission. And so with grade 1s, we're seeing almost an 83% chance of gross total resection and almost a 90% chance of remission. And then as we get higher, grade 2s, about 70 and 60% of remission. Grade 3A and 3B, we're getting in the territory of in the 50%, whereas actually in grade 3B and grade 4, we're seeing almost a 0% chance of endocrinologic remission for these patients. And so as we look, the role for surgery in those circumstances becomes less and less, specifically as it relates to prolactinomas. And so grade 0 is tumor medial to that medial tangential line of the ICA. Grade 1, it's less than 50%. Grade 3A or grade 2 is almost all of it. Grade 3A is encroaching beyond the ICA, 3B beyond the ICA, but inferior to the cavernous, inferior to it. And then grade 4 is complete encasement of the internal carotid artery. And so coming back to that role for a surgical intervention for prolactinomas, and again, while the vast majority of tumors can and should be treated with cabergoline, there is that role for surgery. And this is a recent meta-analysis that was done, which showed that these microadenomas treated with surgery, they had an 83% remission rate in the appropriately selected tumors as opposed to medication long-term remissions, which was in the order of 40%. For those patients. And so you can achieve with an appropriate selected patient a good outcome with surgery and avoid the need for long-term medical therapy, while also having a low morbidity. Second line therapies. And so, oftentimes we are moving to second line therapies where we're increasing dosages, and it really just becomes then a combination of the previous things we discussed, which is surgery and dopamine agonists. And if you use a dopamine agonist and you're not seeing an appropriate response, one, that may show you that you may need to rethink your initial diagnosis if the cabergoline is not appropriately treating a pituitary adenoma, or two, you may have to then think about surgery and vice versa. If you tried an upfront surgical approach and you did not achieve that hormonal remission, you may need to be on long-term dopamine therapies. And so this just goes to show you that it takes a multidisciplinary approach. It takes revisiting, your initial treatment paradigms as well as your initial diagnosis to get a good idea of what's happening. So long-term outcomes for prolactinomas. When can we begin to think about discontinuing medical therapy in those patients where we say we've treated them with cabergoline, we've seen the appropriate response, a decrease in tumor size, we've seen prolactin levels return to normal, we've seen, galactorrhea stopping, return of appropriate menses, or there's no pubertal delay. How long, we can't possibly think about keeping these patients on cabergoline for the remainder of their lives, but how long do we have to have them on their therapy before we can think about discontinuing it? And when we do so, what are those recurrence rates? Do these tumors automatically come back, or is there some delay, or do they stay senescent? And so when can you begin to think about the medical therapy? And traditional guidelines or the current guidelines say that when prolactin levels have been normalized for at least 2 years, and this is with routine, typically every 3 months, checking prolactin levels and then repeat MRIs every 6 months. And then also finding that there's no remnant of tumor on MRI. And so complete remission of these lesions is ultimately when we can think about stopping medical therapy. And that's tough to do as many of these lesions do not completely shrink. Ultimately, then, what are the recurrence rates when doing so? And there have been a number of studies, and they report very, very different recurrence rates, but anywhere from 26 to 89% will have a recurrence rate. And that's largely within those first 2 years. And in those circumstances, these patients are put back on medical therapies, and it becomes really a lifelong disease for these patients, even if, like we said, think about these as benign lesions, ultimately very, very, benign histology in the WHO, but as a result of the hormones that they create, and their tendency to stick around, they can be, lifelong quality of life altering diseases. Okay, so moving away from prolactinomas and onto a different type of hormone secreting tumor, we think of ACTH secreting tumors, which is kind of the next most common one that we think about. And again, the mainstay of this is diagnosis guides treatment. And we start with the history and presentation, and these patients will present. And I write Cushing disease here because when ACTH is secreted from the pituitary gland, it is called Cushing's disease, but these patients will present with what we call Cushing's syndrome. And I think everybody is familiar with this picture on the right-hand side, which is the typical hypercortisol producing patient. Either they've been on long-term exogenous steroids or they have an adrenal tumor or a pituitary tumor causing a number of these things. In the pediatric population, we see them presenting between 11 and 15 years old with excessive weight gain, growth stunting from closure of their growth plates. They'll have moon facies as a result of the hypercortisol secretion, abdominal stria, and then a number of biological complications or chronic diseases that we don't typically think of in children. Hypertension, osteoporosis, impaired carbohydrate tolerance, not necessarily true diabetes, but they'll have carbohydrate tolerance. And then acne and facial hair before they're traditionally supposed to have it. And this table just kind of shows all of the different biochemical testing that you can use to diagnose Cushing's disease. And the first thing is to confirm Cushing's syndrome or to confirm hypercortisol secretion. And typically that's done with a 24-hour urine collection for a number of consecutive days. And again, we don't memorize the cutoff values, but it's important to know the different types of tests that can be used. And then after that, there's confirmation of Cushing disease, which is to find the location of ACTH and confirm that it's coming from the pituitary gland. And this is a very, I'm sure, very small diagram on your guys' screen and very complex. And we've all have this committed to memory, I'm sure. But it basically just goes to show you that there's a number of different pathways to confirm Cushing's disease, and it starts again with that recording cortisol secretion or using a dexamethasone suppression test. And ultimately, when you have the confirmation of Cushing's syndrome, then moving on to a cosentropin release assay or any sort of other types of assays to confirm the pituitary secretion of ACTH. And now I wanted to confirm a little bit or go into a little bit more depth on some of the more unique things that can be done to diagnose Cushing's disease, done less frequently and really only at pituitary center of excellences who have the endovascular procedures available to do the testing, and really only when the biochemical sources fail. But what this is called is inferior petrosal sinus sampling. And so our endovascular colleagues will place a microcatheter actually through the jugular and feed it up into the inferior petrosal sinus, typically on both sides, and actually take sampling of the ACTH release coming into the sinus. And the reason they do this is can be twofold. One, if there is not a distinct lesion on the MRI, but a pituitary source of ACTH release is suspected, meaning full body scans, and they've looked at other sources on the adrenal glands, has not been found. We can use this to try to localize it. And what we look for is actually a 3-to-1 ratio of ACTH in the sinus to the periphery at the time of testing, and that's after a cosentropin bolus, or a 2-to-1 ratio prior to the cosentropin bolus. And that's pretty diagnostic, obviously, for pituitary source of ACTH. The second reason for doing so is we do see a lesion, but it's difficult to lateralize. And we can actually lateralize the region either to the right or left, which can help guide surgical approaches to these lesions, because we'll talk about the treatment options here soon. But it can give the surgeon a much better idea of where the lesion may be, because oftentimes, while they may have a pseudocapsule within the pituitary that can help dissect them off of the normal gland without causing too much damage to either the infundibulum or the gland itself, and reduce morbidity. Knowing the laterality can give the surgeon a much better chance of targeting the appropriate lesion, achieving surgical remission, and minimizing the morbidity. So then moving on to treatment. First-line therapy for Cushing's disease and for these ACTH-secreting tumors is surgical resection. And I know many, maybe you don't believe me because this is a surgeon saying first-line treatment is surgery, but it comes from the idea that there really aren't great medical therapies for this. And so with that, second-line therapy is also surgery. And this is unique in the sense that we offer surgery for these patients, meaning we do an upfront surgical resection of the lesion if it's known, and then we wait. And we keep them in the hospital, and we measure serial cortisol values, and we look for cortisol to drop to a level to where they are in adrenal insufficiency and they'll need supplemental cortisol. And if that doesn't happen within the first few days after surgery, oftentimes second-line therapy is to go back in and do another section. And ultimately, that is a little bit more risky, and there comes with it a higher morbidity, but the chances of surgical remission are higher doing a first-line surgery and a second-line surgery than moving on to either radiotherapy or medical therapies. And we'll talk about that a little bit. Remission rates in patients with these microadenomas undergoing a selective adenomectomy, which is just the lesion itself and not actually doing a hypophysectomy, which is actually taking out the entire pituitary gland in total. Done by an expert surgeon, and the initial surgery is anywhere between 65 and 90%. And while 65% may not seem like an extraordinarily high number, that's a chance for surgical cure of a very debilitating disease for these patients. Now, ultimately, recurrence rates are relatively high. Ultimately 5 to 10% at 5 years and 20% at 10 years. Owing to the fact that these patients need to be followed for their life, and ultimately can, depending on the age of diagnosis, will need to be transitioned to an adult endocrinologist, an adult neurosurgeon to be followed. And then second time surgery has been shown to be efficacious in approximately 2/3. And so even if we use the conservative estimates of 65% remission rates initially, and then a 50% remission rate after a second surgery, we're capturing a very large initial population of patients with these ACTH secreting tumors, and without the need for medical therapies, without the need for radiation to the region, we can get remission in a lot of patients. But unfortunately, those second-time surgeries carry a significantly higher risk of postoperative hypopituitarism, which, as we know, is in and of itself a very debilitating thing to be on hormone replacements for the remainder of your life. So to elaborate a little bit further, then what is the role of radiosurgery for these patients, if there is any? Currently, external beam radiation has become the standard for patients with Cushing's disease where radiotherapy is indicated. And it's another option for those patients who do not want a second surgery. And so it's initiated in the first couple weeks or 2 to 4 weeks after the initial resection if the cortisol levels do not drop. And the reason to delay the radiotherapy, one, we think about tissue healing, but in these transsphenoidal approaches, that becomes less and less of a consideration. But more so, we see sometimes there are gradual drops in the cortisol levels to a level of that we deem remission, which is that morning cortisol less than 1. And it can take weeks sometimes. And so often we wait to initiate radiosurgery to see if we can avoid doing radiation in these patients if we just give them some time. But radiotherapy is somewhat effective, but it takes time, as does all radiation. And so it achieves control of the hypercortisolemia in approximately half to 60% of patients. Again, this is unfair to our radiation oncology colleagues or to radiation, but these are often these more tricky tumors who we didn't achieve surgical remission in and of the first place. And so of those who didn't get remission in the first place, we're seeing remission in about 50 to 60% of those patients. But it takes sometimes 3 to 5 years to achieve that goal of therapy. And then to piggyback off of that, is there a role for medical therapy? I know we saw in prolactinoma medical therapy being the initial treatment of choice. However, in Cushing's disease, for a number of different reasons, that's not necessarily the case. So there's, 2 major therapies that are used, and typically those are just used in patients to reduce the cortisol burden for those who are awaiting definitive surgery or the effective radiotherapy. And so the goal is to not keep patients on these therapies keep them on them for as short of a duration as possible. And that's due to the frequent dosing that these drugs require, often 4 times a day dosing, as well as the constant need for titration based off of the cortisol levels, the continued biochemical monitoring to make sure that the appropriate doses are given. So overall, the treatment of choice for Cushing's disease, surgery, repeat surgery if possible, and then radiotherapy when all else fails, and then using these medical therapies as an adjunct or as a bridge. So let's say that works. We have achieved cortisol drops either through surgery or radiotherapy. We've placed them on their supplemental cortisol so that they have a normal, or what we hope is a normal cortisol level long term. What do we do for follow-up? How long do we follow these patients for? Do they need to stay on continual therapy, or are there other things that we need to be looking out for? And one of the things that I think needs to be noted for a lot of these patients is that while cortisol is the main thing we're thinking of, and secretion is the main thing we're thinking of, in the follow-up, usually within 3 months after achieving a surgical remission, growth hormone testing needs to be done, and the reason being is to prevent that premature skeletal maturity, allow the child to grow as they normally would, and to prevent that short adult stature. Because oftentimes, even in those cases where initially we're not seeing any hypopituitarism as a result of surgical resection, even when we're not seeing any damage to the pituitary that we can see up front, they'll develop a growth hormone deficiency as well. And so a lot of times we need growth hormone supplementation or GnRH therapy to delay puberty, prevent the closure of growth plates, and achieve skeletal maturity. And because again, that even if we achieve a good surgical remission and we think your disease is cured from a surgical standpoint, the hormone imbalances can be devastating to these kids, and especially as they they may not achieve their normal adult stature, or may not achieve their normal development, and that can result in those neurocognitive and psychosocial issues that plague them for their life. And then furthermore, when we look at overall hormone deficiency, sometimes they can present late. And so every 6 months, a full pituitary hormone panel is indicated, at least for those first 2 years, to make sure that we're not seeing any delayed effects of surgery or radiation in these patients. So these are extraordinarily tricky diseases that require very, very close attention to be made. And then something that I wanted to bring up that I mentioned very early in the talk, but I wanted to circle back to because of maybe potentially overlooked is the effects of hypercortisolemia on neuropsychiatric issues with patients and how even treating their disease and removing the adenoma, these patients still unfortunately do experience a number of psychiatric and neurologic or cognitive deficits. And we know from both the adult and child populations that excess glucocorticoids has been shown to lead to brain atrophy, cognitive impairment, and depression. Fortunately, after adenomas are removed or the hypercortisolemia is corrected, we do see restorations to normal brain volume. Cognitive impairments and psychological deficits do tend to persist. And studies have reported up to 25% of these patients postoperatively have psychiatric disturbances, largely depression, that need pharmacological assistance. And then 14% some have some level of memory impairment. And I think this is due to some studies have demonstrated that hypercortisolemia results in specific volume loss within the temporal lobe, the amygdala and hippocampus, which, as we know, is very important with memory and cognition, as well as our integral structures with the limbic system. And then finally, as it relates to ACTH releasing tumors, relapse rates are high, and they can be seen up to 60% often within the first 5 years. And it requires, going back to step one, which is that initial therapy with surgical resection and potentially with radiotherapy if needed. So I know I sound like a broken record, but to drive home the point that these patients need long-term follow-up, multidisciplinary care, and it's important not to lose these patients to follow-up because while an initial great outcome can be achieved, these diseases can persist. We'll move on to our somatotropinomas or our growth hormone secreting tumors. And again, diagnosis guides treatment. These understanding what is being secreted, what the tumor is creating, ultimately can help guide the treatment options to achieve the best outcome. These growth hormone secreting tumors have an annual incidence of 3 to 8 per million cases, so they're extraordinarily rare. And so when they are seen, it's important to kind of know how they will present and in order to achieve an accurate diagnosis and ultimately treatment. And so that comes with, again, the history and physical. These patients will present with what we call gigantism. And there's a specific definition of pituitary gigantism, which is, the biochemical analysis with growth hormone or IGF-1 excess, and that's associated with accelerated growth over 2 times the normal standard deviation that is adjusted for age and country specific, as well as sex specific height or weight norms. And then it's important to note that this is just seeing gigantism is, we think about it as traditionally some patient with gigantism, they have a growth hormone secreting tumor, but a lot of times it's genetically related. It can be related to McCune Albright, a number of other diseases. And that's furthermore, just a emphasis on the biochemical analysis. And so we see the goal is to look for growth hormone suppression with an oral glucose load, and that'll show us that there is some level of growth hormone excess that we can then localize to the pituitary gland through our neuroimaging. And so importantly, like we talked about initially, the smattering of pituitary hormones that's done when an initial tumor is seen, and in prolactinomas, in ACTH secreting adenomas, we think of just those just those specific endocrine abnormalities being seen in the microadenomas. Growth hormone tumors, by contrast, actually have a number of other pituitary hormone abnormalities that can be seen with them. Most commonly prolactin co-secretion, which can be seen in about 30% of cases with somatotropinomas. And so you could see a mixture of presentation with that amenorrhea, galactorrhea, in addition to the gigantism and all the number of things that comes with this. So the treatment for these tumors is offering, the guidelines suggest offer surgery as the treatment of choice for the majority of these adenomas, even when surgical cure is unlikely. And I put a picture of the suspicious Smurf there because I'm sure that bolded statement there, even when surgical cure is unlikely, is a little hard to wrap your head around. And people may just be thinking, here's a surgeon recommending surgery, even when they say they can't, achieve a cure with surgery. But there's a specific reason for this. And it's that one, surgery offers the prospect of complete remission for these patients. And then even if it is unlikely to achieve remission, the tumor debulking actually has a stepwise effect on the growth hormone secretion, and it can facilitate better success with medical therapies or radiotherapies in the post-operative setting. Again, surgical cure rates are, not extraordinarily high. One center in the 13 years of their experience, they had 17 of these tumors, and they only corrected or saw a success rate with surgical remission in about 50% of cases. And so these are tricky diseases to treat. And so then we offer medical therapies, either in combination or as monotherapy postoperatively for those with residual growth hormone secretion. And we can see that, the goal, unlike cabergoline for prolactinomas, where we're actually trying to achieve a medical cure by giving the dopamine agonist to reduce tumor volume, to relieve symptoms, and ultimately, hopefully, to achieve remission if they've had, greater than 2 years without the tumor presence on MRI and with normal prolactin levels. Medical therapy in the setting of growth hormone tumors is just aimed at reducing the levels of growth hormone to safe levels. And the medical therapy can do that in approximately 35% of patients, and with a less predictable tumor shrinkage in up to 40. And so we don't see that same level of medical efficacy that we do in the prolactin secreting tumors. And maybe that's because we don't have a great medical therapy and we need one. And I would offer that we certainly do, given that surgical success rates are not extraordinarily high, and medical therapies afterwards are not extraordinarily effective either. The role of radiotherapy, and I don't have a specific slide on this, is more limited in these tumors because the very sparse data, but the data suggests that it can be up to 10 years after radiotherapy for these to be effective, and that medical therapy to help normalize those growth hormone levels in the interim are needed. And so, really the mainstay is the surgery plus medical therapy, at least from what we've seen so far. And then ultimately follow up for these growth hormone tumors. These patients will need, we talked about this, patients will need long-term monitoring and ultimately will need to be transitioned to an adult endocrinologist and neurosurgeon at some point in their lives. Lastly, I don't have a highlighted hormone here because we'll move to, the more frequent tumor in adults, but much less frequently in kids, is the non-functioning pituitary adenoma, or the incidentaloma. And those are diagnoses of exclusion, meaning we have to go through all of the smattering of tests, the smattering of neuroimaging, including the pituitary hormone function, as well as a number of other tests, including alpha-fetoprotein or beta-HCG testing, to rule out intracranial germ cell tumors, which are actually more common in children than the non-functional pituitary adenomas, which make it, all the more, essential that we achieve the correct diagnosis and not assume, based off of our adult literature, that if pituitary function is normal and we see a sellar lesion, that we assume that this is a non-functioning pituitary adenoma, because in kids we see Rathke's cleft 6 germ cell tumors with a bimodal distribution where there is a pineal tumor as well as a sellar tumor. So all of these need to be measured and ruled out before we can say, this is a non-functioning pituitary adenoma. And then ultimately we get into, if it is, and we do ultimately suggest that this is a non-functioning pituitary adenoma, what do we do? And largely it's based off of observation. Unless there is visual disturbances that are a result of mass effect. And so many times these patients can be followed with serial imaging. Current evidence guidelines suggest there is no role for a diagnostic biopsy in these patients, and that when biochemical analyses are normal, and there are no other intracranial abnormalities, like we talked about, no visual disturbances or hydrocephalus, anything like that, that the role of biopsy is not indicated, and that when those things are present, visual decline, hypopituitarism, or significant interval growth, the treatment of choice is surgery, as there is no medical therapy or consistent and well-studied medical therapy for the non-functioning pituitary adenomas. And then ultimately, if we do operate on those patients, surveillance is done at a minimum of 3 and 6 months, and then 1, 2, 3, and 5 years. And I won't go into the specifics of the microadenoma and macroadenoma differences in interval imaging. With that, I will pause for questions. I had a single case that I was going to go through, but I think in the interest of allowing for questions, I will stop there and just say, again, thank you to Dr. Bristol, Dr. Hopman, Dr. Shafran, Dr. Ronacher, the rest of the neurosurgery team for allowing me and teaching me over the last 2.5 months. I'm excited for the last 2 weeks, and I've learned a tremendous amount. And I hope I've shared with you knowledge on a disease process that is very common in adults, but very uncommon in children, but nonetheless can be very debilitating, can have long-term effects, and but can be treated with good success rates if there is an understanding that diagnosis guides treatment, and that the appropriate workup and treatment paradigms are used in those cases. Thank you.
Thank you, Nick. That was definitely a tour de force of this topic. And, I have a comment more than a question, which is just that I've been doing this for, however many years now, and I still don't keep on the tip of my brain the management for each of these things. So I think it's really useful to have somebody go through it and just, remind us which of the things we treat, which of the ones we follow, and medical versus surgical. So thank you for that. That was nicely done.
Yeah, I echo Ruth's comments. So, Nick, can you give us maybe 2 or 3 technical pearls that you have learned over the last couple of years of your residency that you think is really helpful to keep in mind when approaching lesions in the sellar region?
From a surgical standpoint?
Sure. Yeah, it can be anything you want from diagnostic to surgical, but maybe some surgical pearls that you've picked up along the way.
Yeah, I think from a diagnostic standpoint, I think most people know this with prolactin elevation, even minor elevations do not indicate prolactinomas, and that you need, profound prolactin elevations for that to be the case. And oftentimes, physiologic stressors, or even in children, just changes in their normal hormonal environment can result in increases in prolactin. And so I think just having a keen eye to look out for that helped prevent patients who do not need medical therapy with cabergoline from being treated with it. And then from a surgical standpoint, I think endoscopic transphenoidal approaches in experienced hands result in much better outcomes than we were seeing previously with the open cranial approaches. And I have emphasis on the experienced hands, and I didn't show any data on the learning curve there, but to adequately treat these tumors, know which ones you can achieve surgical remission on versus the ones where going in, you're going to be doing a tumor debulking, takes a very experienced surgeon Oftentimes when you drill out the sella and you look at the pituitary gland, the adenoma in and of itself is not immediately visible. And it's that understanding of the preoperative MR imaging, understanding of where your cavernous sinus is from an intraoperative view, and the extension of the tumor, whether it may or may not be in the cavernous sinus. That is really the key to one, trying to achieve surgical remission, and two, knowing your limitations to not cause damage by incidentally damaging the pituitary gland and causing more morbidity than benefit, and then and achieving a maximal safe resection.
Yeah, thanks, Nick. That was terrific. One comment I'll make about the first thing you mentioned, which is physiologic or super physiologic prolactin levels in the setting of, stalk effect, is that for those of us who are not surgeons on the call, there is something called the hook effect, which can occur in very large prolactinomas, in which the prolactin levels are actually so high that it saturates the test that detects prolactin. And so it's going to look like it's only marginally high. And so if you see a child who has a large sellar mass and a very sort of like mildly high prolactin level, you generally want to order it with serial dilution to make sure that you're not just seeing a falsely marginally elevated prolactin level in a large prolactinoma. I just want to throw that out there. But that was terrific, Nick. Thank you so much.
Yeah. Thank you, Dr. Hoffman. I appreciate that comment. Didn't mention the hook effect in there, but I think that's a really important thing to note. All right. Thank you, everybody.
Have a great day, everybody. Bye-bye now.